I'm thrilled to introduce our next speaker, Representative Doris Matsui, who has represented the 6th District of California since 2005. In 2018, Congresswoman Matsui co-authored a bill to promote testing of incentive payments for behavioral health providers to adopt and use certified electronic health record technology. This led to the BIT Coordination Act, providing a total of $20 million to finance behavioral health IT adoption. Let's welcome Congresswoman Matsui to the APAICS Health Summit.
Hi, everyone. It is wonderful to join you today at the APAICS Health Summit. I want to thank Madeline and everyone at APAICS for bringing us together and organizing this wonderful event. Events like these spark discussions about the future and how we can pool our resources and knowledge to move the needle. In our AA-NHPI community, we often come up against overgeneralizations and stereotypes. Yet those of us here know that our community is a widely diverse tapestry of cultures and ethnicities. That means our solutions must incorporate all of those diverse voices. The past few years have had an immense impact on our community. We have lived through an unprecedented global pandemic. Our entire healthcare ecosystem was challenged to the extreme. Providers had to quickly adapt. Patients had to learn how to navigate a new normal. The pandemic also drew the curtain back on our country's mental health crisis. Since the beginning of the pandemic, about half of Americans have reported experiencing symptoms of depression and anxiety. Specifically in our community, we have confronted an onslaught of anti-Asian hate. The impact has been enormous in our community and beyond. I have long been sounding the alarm on issues of mental health, from bolstering a mental health infrastructure to expanding access to quality mental health care. I'm proud of authoring the legislation that established the Certified Community Behavioral Health Clinic program. And last Congress, we were able to secure a nationwide expansion. Now we are looking at ways to capitalize on this progress and make CCBHCs a permanent part of our healthcare safety net. Mental health is just one piece of the puzzle, but we are continuing to fight hard across the board. Monumental legislation, like the Affordable Care Act, continues to stand as a pillar of health and financial security for American families. The Inflation Reduction Act has been transformative, allowing Medicare to negotiate directly with drug makers, capping insulin at $35 for Medicare beneficiaries, and extending important subsidies to keep insurance affordable for millions of Americans. And while I'm sure this coming panel will talk about many policies that shape access, equity, and quality of care, I want to talk to you all about something that I'm very passionate about: the intersection of healthcare delivery and technology. When we talk about increasing health equity, we know that the key is to remove barriers to care, to address existing inequalities and disparities in the system. That's why I'm such a staunch advocate of telehealth, empowering folks to pick up the phone and follow through on appointments, enabling people to get care sooner, ensuring access to culturally competent care and language-inclusive services wherever a patient is. That is the transformative impact of telehealth. I know I don't need to remind anyone here, but healthcare looks different than it did a decade ago, and radically different than it did even a decade before that. And the laws of the land should reflect that transformation. That's why I'm leading legislation to ensure Americans can continue to capitalize on these benefits. What is clear is that we will continue to lead each and every one of you to stay engaged. We need for you to do that, to start new discussions, to push for the change that you want to see. Thank you all for being a part of the summit, and have a wonderful rest of the event.
Our next panel is Navigating the Impact, Analyzing Federal Legislation on Healthcare and Access. AA and NHPIs experienced larger relative gains in health insurance coverage than any other racial group in the United States since the Affordable Care Act was fully implemented in 2014. However, many in our community still remain uninsured, with Korean Americans at 10% and NHPIs at 12.3%. This panel will delve into the intricate relationship between federal legislation and healthcare outcomes for AA and HPI communities, discussing the various policies that shape access, equity, and quality of care. Experts in healthcare policy, advocacy, and community will explore the impact of federal legislation on AA and HPIs, addressing both the successes and challenges encountered in pursuing comprehensive and inclusive healthcare. I'd now like to introduce our moderator for this panel, Princess Visconde. Princess is the Senior Manager of Community Engagement at the Asian and Pacific Islander American Health Forum. She earned her Bachelor of Science in Biology from St. Mary's College, as well as her Master of Public Health degree specializing in health policy and management in Certificate in Public Administration, Nonprofit Management from the University of Hawaii at Manoa. Princess has extensive experience working for nonprofit and government organizations, including the Hawaii Children's Action Network as a public health research fellow, and the Hawaii State Department of Health as a disease investigator. Thank you, Princess, and welcome to our panelists.
Thanks, Madeline. Hi, everyone. Thank you all for joining the APAICS Health Summit. My name is Princess May Visconde, and I'm a Senior Community Engagement Manager at the Asian and Pacific Islander American Health Forum. I'm excited to moderate this amazing panel of leaders where we will discuss the impact of federal legislation on healthcare and access. So we have on this panel some incredible leaders who I'll briefly introduce. We have Adam Carbullido, Director of Policy and Advocacy at the Association of Asian Pacific Community Health Organizations, APCHO. Paulo Pontemayor, Senior Director of Government Relations at Catholic Hospital Association of the United States. Jennifer Rasing, Global Lead Pan-Asian Network PAN at Bristol Myers Squibb, and Dr. Mike Ybarra, Senior Vice President and Chief Medical Officer at Phrma. Thank you all for being here and participating in this important panel. I'd like to launch our discussion by having each of you describe your role and also answering what is the current state of healthcare legislation. Describe your organization's perspective on this issue and how it impacts the AA and HPI community. Adam, let's start with you.
Thank you, Princess, and thank you, Madeline and APAICS for having me. I'm Adam Carbullido, Director of Policy and Advocacy with the Association of Asian Pacific Community Health Organizations, or APCHO for short. We are a national nonprofit association of community-based healthcare provider organizations, primarily federally qualified health centers, that work to improve the health status and outcomes of medically underserved Asian Americans, Native Hawaiians, and Pacific Islanders in the United States, the U.S. territories, and the freely associated states. So before I get into the status of federal legislation and how they impact the Asian American, Native Hawaiian, and Pacific Islander communities, just to provide some context that I think would be important for everyone, is that when we're talking about AA and NHPI communities, we're not talking about a monolithic community. Our communities trace their origins to more than 30 countries, comprising more than 50 ethnicities and speaking 50 different languages. And I think it's really important to recognize the diversity of our communities because each population group can experience healthcare in the United States differently. And we are also impacted by geographic location. We have individuals who reside in the 50 states, and there are some variances depending on what state you live in. But then there are also Native Hawaiians, Pacific Islanders, and Asian Americans that live in the U.S. territories. And the different ways in which territorial status impacts healthcare for our communities. There's also differences in the way we came to the United States. There are many of us who are first, second, third generation Americans or have been recently naturalized, and that comes with the way in which they experience healthcare. There are also many immigrant communities within A and NHPI family. And then there are also those who are part of the US family because of colonization. And I think it's these important contexts that really underscores how we experience healthcare in the United States and the different interventions that we need to see in order to ensure that our communities do have equitable access in healthcare and that we are appropriately providing resources to them so that they can have positive health outcomes. In terms of, the status of federal legislation, there have been many that have worked to improve health status and outcomes for our communities. The Affordable Care Act, the ACA, helped to greatly reduce helped to reduce uninsurance for our communities. But there are many, particularly among Native Hawaiians and Pacific Islanders and some South and Southeast Asians that have disproportionately high rates of uninsurance. The Inflation Reduction Act did have a positive impact on Asian American, Native Hawaiian, and Pacific Islander communities. Again, like providing additional tax credits so that low-income individuals could receive additional assistance in order to afford insurance. The Consolidated Appropriations Act of 2020 helped to restore Medicaid coverage for some Pacific Islander communities, those from the Compacts of Free Association, who lost Medicaid coverage because of the 1996 Welfare Reform Act. The 2023 Consolidated Appropriations Act helped to greatly increase the reimbursement rates that citizens from who reside in the territories are able to get when they obtain Medicaid coverage. And just recently, the Consolidated Appropriations Act that was signed on March 9th into law restored other federal benefits coverage for COFA citizens. And I think all of these have been important improvements for our communities. But I think when we're thinking about how our communities are experiencing healthcare, some of the best ways that we have found to address healthcare in our communities is when legislation provides flexibilities on the use of resources for government programs so that individuals can receive healthcare in ways that are culturally and linguistically appropriate to themselves, and so that interventions can be specifically tailored to different communities. Because like I said, our communities are very diverse. We come from different cultural backgrounds. We speak many different languages. So when we can provide interventions that are culturally and linguistically tailored, which we've seen across many pieces of legislation and through regulations in the federal government, that helps to really improve healthcare status for our communities.
Yeah, thank you, Adam. Thank you for really setting the stage for us and really highlighting the diversity and uniqueness of the ANHPI communities. Then I'll ask Dr. Ybarra to chime in next. What are some trends you are seeing in the healthcare setting as it relates to legislation?
Thanks. Yeah, it's great to be here. My name's Mike Ybarra. I'm an emergency physician by training. I see patients in the emergency department here in Washington, D.C. And I'm also the chief medical officer at Phrma. And Phrma is the Pharmaceutical Research and Manufacturers of America. We are a trade association that represents the 32 innovative companies that are really doing amazing things to change the world. I've been a physician. I graduated medical school in 2008. So it feels like I've had a relatively short medical career, 16 years since medical school, a little less than that since finishing residency. And I can tell you over the course of roughly 15 years, there are a number of diseases that I learned about in medical school that what I learned was completely wrong. There are diseases that were taught to me as a death sentence that are now treatable or in some cases curable. And there was an amazing story over the weekend in the Atlantic, if folks have time to read it. It was about cystic fibrosis, which brought back a lot of memories for me. It was an article about how new therapies are changing the standard of care for individuals with cystic fibrosis. And I remember taking care of young kids when I did my rotations in a children's hospital. And I believe we have a hospital representative coming up. But I remember taking care of kids with cystic fibrosis in the emergency department. And they were so incredibly sick from severe infections, from antibiotic resistant infections. And so many of them had a shortened life expectancy or had even worse outcomes. And that's totally changed now. In just 15 years, people that can get on therapy for that disease are able to live long and healthy lives. And that's a really dramatic example, but there's a number of other examples of innovations that have changed the course of diseases. And there's much more that we have to do. We know, for example, that stomach and liver cancer is a disease area that disproportionately impacts the API community. And we're not where we need to be in terms of researching new treatments, but we have to support innovation and support the R&D ecosystem that brings those patients the treatments that they need. And unfortunately, the policy environment, in our view, isn't always keeping pace with that level of innovation. It's sort of a shame. I don't think I'll surprise anybody on this call that the biopharmaceutical industry is often a political populist punching bag from both sides of the aisle. And that doesn't really always fit with the industry that I know and the medicine that I've been able to practice and bring to patients as a result of the collaboration between industry and physicians. So I think that Adam hit on a lot of the pieces of legislation that we are most focused on. The biggest one being the Inflation Reduction Act that passed recently. It had a large healthcare title and it had a large component of drug pricing legislation. And like any piece of legislation, there are going to be good things, but there are also going to be things in our view that are harmful to innovation. The good things include things like the out-of-pocket cap in Medicare Part D and redesigning the Medicare Part D benefit. That had bipartisan support sort of on its own. But then there are some harmful things like price control mechanisms that are already having an impact in the way that drugs are developed and brought to patients. So I'm sure we'll dig in on all of that more over the course of this conversation. That's most definitely the biggest piece of legislation that we're focused on. And I appreciate being a part of this conversation. Thank you for the invitation.
Dr. Ybarra, thank you so much for highlighting our communities and really ensuring that they're included when it comes to the science being changing and evolving, and also the legislation changing and evolving. Paulo, what are your thoughts?
Sure, thank you, Princess, and I'd like to thank APAICS for sponsoring this. I'm a proud alumni of APAICS's programs, and I, have really seen how public policy, especially for those of us who are in the A and NHPI population, really can only be enhanced by our involvement. And the APAICS programs, especially their congressional fellowship and internship programs, have really transformed the way that I was able to get into my role. The Catholic Health Association is made up of more than 600 hospitals and 1,600 long-term care facilities and other healthcare organizations across all 50 states and several U.S. territories. The Catholic Health Ministry is actually the largest group of nonprofit healthcare providers in the country, with more than 7 patients in the U.S. being cared for in a Catholic hospital on any given day. The Catholic Health Association has really been around more than 100 years. We were founded in 1915, but going back even further, several of our individual members were created even earlier. We trace Catholic healthcare going back to as far as 1727, even before the United States was founded, when the Ursuline sisters were asked by the colonial governor of New Orleans at the time to come from France and to care for residents. And so this commitment to working in underserved areas and working with vulnerable populations has really informed Catholic healthcare's work. Adam has been so great at mentioning all the great things legislation-wise that we have supported really within the last 15 years, the most principal one being the Affordable Care Act, which the Catholic Health Association has really pushed for back in 2010. Studies have shown that Asian Americans and Native Hawaiians and Pacific Islanders had the largest increases in healthcare coverage through the ACA, decreasing their uninsurance rate by close to 54%, the largest improvement among any racial and ethnic coverage group. So legislation that we're supporting at the Catholic Health Association include ways that we can continue to expand and enhance coverage to ensure that the ACA's promise is made. We look for extending the enhanced subsidies that were part of some of the pieces of legislation that Adam had mentioned, the Inflation Reduction Act and the Consolidated Appropriations Act, and seeing how we can actually increase and get healthcare coverage for even more people. We know that A and NHPIs are most likely to enroll in marketplace health insurance coverage and also have high insurance coverage rates compared to the general population. I think we've seen kind of the disparities and kind of the demographic makeup in the community. Many A and NHPIs are actually small business owners. And so being able to have a resource for where people can get coverage for themselves, their families, and their employees is such an important piece. Older estimates have actually showed that because of the ACA's work, 150,000 A and NHPIs have zero premium coverage, and close to 200,000 were made eligible with new coverage because of some of these ACA subsidies. So we really want to protect the ACA and build on those gains. We know that there still are a lot of people in our population that are not covered under these new benefits in law, including our undocumented communities, as well as those residing in states that have not expanded Medicaid. So we at the CHA have been really pushing for Medicaid expansion in the 10 remaining states. We also know that Medicaid redeterminations continue to be an issue. That's why at CHA we launched a national campaign that involved all of our members called Protect What's Precious, which really has made kind of a consumer-facing product. So we now have outreach materials, an innovative QR code that our members can access or put forward in their waiting rooms, and really any outward patient-facing resource to ensure that they have the right information to get connected to their state and local health agencies to ensure that they do not lose Medicaid coverage. We also know, again, that our work is not done. Once you have health insurance, there is really this challenge of making sure that you stay on it and do not get kicked off. So we really were really proud to work on legislation that enhanced continuous eligibility for 12 months for children, adolescent and teens in Medicaid and CHIP, and up to actually age 19. So I don't know what you would categorize them, I guess, young adults, to make sure that they don't lose their coverage. And we're now looking at ways for how we can continue to have this continuous eligibility for more populations, knowing that coverage churn is a big proponent or a big issue when people are looking at making sure that they have a primary care home, making sure that they have an access to care or relationship with their primary care provider. We want to make sure that we have that. We also know that Medicaid postpartum care for women and babies is an important piece. And so we're really pleased to see the nationwide adoption of an option for coverage of Medicaid, or having Medicaid cover women and babies 12 months after women give birth. And so that's something that we were able to work closely with our Senate counterparts, especially some who had concerns about why are we continuing to expand care. And we know that maternal health disparities really do exist, and a lot of the time they exist after delivery. And so we want to make sure that there is a resource for coverage for many of those populations. And lastly, I can't go without saying that we are now having what's called the silver tsunami in the next couple of years. How do we care for our aging population as baby boomers and older populations age? We know that these new populations are going to be a challenge for the healthcare system moving forward. How do we have a long-term care environment, or aging in place environment, or home and community-based services environment that ensures the dignity of people wanting to age wherever they'd like to? Our parents, our grandparents are getting older. Soon we will also get older. And so what can we do as a country to think about how we can support our aging population? And we have some good ideas, but also know that this is one of those places that we hope the healthcare industry, healthcare policy world will look to. And so thanks for having me here today.
Thanks, Paulo. Thanks for sharing some of the great work your organization is doing and the support behind different legislations. Jennifer, I'll turn to you now, kind of sharing what is the current state of healthcare legislation, and more specifically, what are the IRA's impacts on our community's access to medicine, and how does it or does not address health equity?
Right. Thank you. Thank you, Princess May. It's really an honor to be here with APAICS, the Health Forum, and my fellow panelists. So I'm Jennifer Rasing. I've been with Bristol Myers Squibb for 20 years. I held diverse roles as a research scientist, a clinical trials manager, compliance auditor, and now serving as a global Pan-Asian network lead for the company. And my main focus is really to champion and advance the outcomes of our Pan-Asian community, to empower inclusion, diverse perspectives, advance health equity, and really reimagine what's possible. And at Bristol Myers Squibb, we're driven by a single vision: transforming patient lives through science. Every day in every country around the world, patients are waiting. They're the center of everything we do. They inspire us, and they are the reasons why we come to work each and every day. So as the healthcare industry continues to evolve, BMS continues to really place its people at the center of this dynamic, right? Our workforce reflects the diversity of the patients we serve. We are intentional to include people with different perspectives and background to really drive innovation and a collective impact as we create a sustainable and equitable outcome for all. Externally, we are here to build authentic relationships with our stakeholders across the industry and across the public and private sector so that we can really address the huge systematic issues that are impacted our communities. And to be honest with you, it is a real privilege to lead PAN, our employee people resource group, because our focus is really to advance health equity and social justice for our community, looking at health disparities and the unmet need of our Asian and AA NHPI communities, to really work diligently to develop and implement initiatives that support our communities, really providing community outreach and underserved and programs and underserved initiatives. We partner with organizations, hospitals, advocacy groups, CBOs to really understand the unique needs of our patients and communities, because we are a diaspora, right? And we really want to ensure that they have access to the high quality care and that their voices are really being heard and valued. So at BMS, our vision is for health equity and access to healthcare. It's for people of all communities across the globe to attain innovative medicines, regardless of where they live, where they come from, right? We really believe that patients who can benefit from our medicines should also have access to them. As Dr. Ybarra was saying, we are concerned about the impact the IRA will have on access to medicines for patients, as well as the future of innovation, right? Being a scientist and spending half of my career on the bench, and I really reflect back to where we were 20 years ago and to where we are now, I still get goosebumps, right? The innovative therapies, the treatments that we have in our pipeline is incredible. And with the IRA putting in place these policies that require companies to sell their medicines at government dictated prices, it's a serious concern about the impact that we're making, right? This will also have a huge impact, not just in R&D, but our people in underserved communities. So I'm sure we're going to talk more about that, but a lot more for us to do. Thank you.
Yeah. That is a great segue to my next question, which you'll start us off with. How can healthcare legislation better include marginalized communities, including the AA NHPI community?
Yeah, and that's a great question. I think that the IRA has failed to address health equities, including social determinants of health. So really, the CMS must ensure that a diversity of patient voices and perspectives is heard and reflected, and that they're committed to the ongoing two-way discussions on health equity. And as the IRA is implemented, also ensuring patient access, right? They should enact these guardrails to ensure that the UN practices do not limit patient access to medicine.
Great, thanks, Jennifer. Dr. Ybarra, we'll go to you. What are the prospects for additional healthcare legislation this Congress?
Yeah, it's a great question. I think, it's an election year, as I think everyone knows, and there are a variety of must-pass legislation, variety of pieces of must-pass legislation, including government funding that's coming up here soon, and there'll be more as the year goes on. So that always creates an opportunity. But I think from our standpoint, we're mostly concerned, as Jennifer mentioned, about some of the impacts that we're seeing from legislation that's passed. And I just want to double click on some of the points that were made with respect to the Inflation Reduction Act. One of the things that we're really concerned about is that the assumption is that once a drug comes to market and it's FDA approved, that's sort of like the end. And that's really honestly just the beginning of the knowledge that we need to have and learn about a medicine to better understand all the uses and the potential that it has. When a drug's FDA approved, they're developed over the course of their lifespan. And then after a certain period of time, that drug becomes generic. They drop significantly in price. And as a physician, most of the drugs that I prescribe are low cost, inexpensive generics, really low out-of-pocket costs, very, very significant savings to the US healthcare system. It's one of the only aspects, I think it is the only aspect where at a certain point prices will drop by 90+%. But in that time before a drug goes to generic, we learn as much as we can about that medicine. And that includes studies in different patient populations, which I think is really relevant to this panel that we're having right now. Being able to have subgroup data, understand how that medicine might do in different patient populations, what diseases could it also be expanded into? That all requires years of research. Sometimes it takes a decade to ask a really complicated clinical question, like, is this going to have an impact in one subpopulation for a specific disease area? So again, it's not on day one that we know everything about a medicine that's approved. It takes a long time to answer all of those questions. And then at a certain point, the life cycle is over, the medicine goes generic, prices drop significantly. But we know that at the same time, the system isn't working as it should for too many patients. In fact, 50 cents on the dollar of every brand name medicine goes to someone other than the manufacturer. 50 cents on the dollar. So for every dollar spent on a brand name medicine, I think the presumption is that 150% of that goes to the manufacturer, when in fact it's less than 50%. Other folks in the supply chain are taking those dollars. Out-of-pocket costs when a patient goes to the pharmacy counter aren't set by the manufacturer, they're set by the insurance company or the pharmacy benefit manager. And so getting back to your question, what reforms might we see? We're hopeful that we could see some reforms to the pharmacy benefit manager system that's in place right now. We're hopeful that Congress could address some of the perverse incentives that exist in the system right now that really sort of enrich middlemen in the system but are harmful to patients and can lead to significant delays. So we're hopeful that in some of the must-pass vehicles or in some of the healthcare legislation that might come out, we can get at some of those practices and really lower patient out-of-pocket costs.
Thanks, Dr. Ybarra. Paulo, how about you? What should we be encouraging policymakers to do to better include marginalized communities and address health equity?
Thanks for that question. This is always a fascinating one for me, for someone as a student of public health and who has worked in public health, to ensure that communities that are farthest out of decision-making tables have a voice. There's a saying here in Washington, D.C. that if you don't have a seat at the table, you're probably what's being served on that table. And so how do we look at the most marginalized groups? How do we look at those who have the most to lose in any policy proposal? And how do we actually make it so that we can continue to champion true health equity to benefit really all communities in a way that is meaningful, sustainable, and also really honors kind of the commitment of what we're trying to do? One of the pieces that we continue to look at as part of the provider world is how do we get more resources to providers and communities who actually are serving some of these vulnerable communities. One of the things that we have seen as part of the agreement that was passed very recently was what's called the Medicaid Disproportionate Share Hospital payment program. And that was extended to the end of the year. We also know that there were, I'm sure my colleague Adam will talk about this, the federally qualified health center program. How do we work with community health centers who serve really large parts of these populations? We also at CHA are looking at this in a more holistic way. As a not-for-profit provider of care, we also know that we provide community benefit to communities that we serve. What are the things that we can use to ensure that the community health needs and community health is improved? We have programs that our members have run to look at what are ways that we can prevent food insecurity, what are ways that we can look at training the next generation of healthcare workers, healthcare physicians, nurses, and other healthcare providers to reflect their communities. And a lot of that can't happen without support for providers. And so we really look at Congress for ways to not cut funding for through the Medicaid program or Medicare. We need to make sure that Congress understands the unique role that hospitals, healthcare systems, and other entities and healthcare organizations provide for the communities that they're in, and really look at the value of not-for-profit healthcare and what it means in our communities as well. So we're hopeful that Congress looks at any proposals to ensure that we strengthen the needed investments, the needed support for providers. The recent news cycle showcases how some challenges, especially around cybersecurity, can really imperil hospital operations, making sure that those services being reimbursed be done in a way that also takes into consideration that the margins at hospitals and healthcare providers are pretty low. We're really coming out of the days of the COVID-19 pandemic. Hospitals, providers are still finding ways to find value because healthcare, as we all know, is one that continuously needs to be innovative to provide care for as many vulnerable populations and populations in general. And we can only do this if we have resources that continue to support healthcare. So we're hopeful that Congress understands that hospitals, especially emergency room departments, have to run 24/7, 365 or 366 days a year in terms of a leap year. And what are some ways that we can continue to partner with that? Looking at it also from a health equity angle, because many of the times the providers that are serving communities most in need are sometimes the ones that really need most of the resources as well. And we're willing to work with Congress to get that done.
Great. Thank you so much, Paulo. Adam, your organization advocates for unique and diverse health needs of ANHPI communities. How can healthcare legislation better include our communities?
Yeah, thanks, Princess. And I just want to, uplift a lot of what Paulo was saying as well. I think that there are three primary areas that I would hope that legislation would address the needs of Asian American, Native Hawaiian, and Pacific Islander communities. And first, it's really supporting cultural and linguistic needs of communities. As Paulo mentioned, the recent Consolidated Appropriations Act that was passed did provide additional funding for federally qualified health centers, FQHCs, and dish hospitals and some of their community-based providers through the end of the year. And it is investments in organizations and healthcare provider organizations that do provide culturally linguistically appropriate care and care for communities that are underserved in order to address the unique needs that they have. I think it's important that Congress continue to invest in community-based organizations who are often at the front lines and who partner with healthcare providers in order to translate materials, serve as interpreters, provide connections to the social determinants of health, and provide other connections to address the unique health status of our communities. Secondly, I think that we should continue and require the collection and reporting of disaggregated data, particularly for Asian American, Native Hawaiian, and Pacific Islander communities. As I said at the top, we are a very diverse community that experiences the healthcare system differently. And it is only through understanding how different segments of our community and our populations are disproportionately impacted by diseases and by other health interventions that we can really provide cultural and tailored interventions in order to ensure that we are directing resources in the most efficient way possible. The third point that I want to make is that we really need to direct more federal dollars towards AN and HPI specific research. I read a health stat recently that only about 1% of all federal research dollars goes towards AN and HPI specific research projects, despite our communities comprising about 8% of the population. And it is only through really understanding how healthcare challenges are affecting specific segments of our population that we are able to ensure that we are directing federal resources appropriately and that we are using federal resources in the most efficient way possible. So I think that in order for Congress to really support Asian American, Native Hawaiian, and Pacific Islander communities, it's supporting the providers and community-based organizations that are on the front lines, ensuring that federal data systems are collecting and reporting information on our communities specifically and disaggregated so that we are seeing how Japanese Americans are experiencing healthcare different from Chinese Americans, from Vietnamese Americans, from Korean Americans, from Native Hawaiians, and from Pacific Islander communities, the Chamorro community, the Marshallese community, the Palauan community. We all experience the healthcare system differently. And lastly, directing federal research dollars so that we can have the evidence and the intervention based information in order to direct tailored responses to the unique challenges that we experience.
Amazing. Thanks, Adam. Yeah, spot on with what you said. Our communities are so diverse and unique. And as we shared today, it continues to change and evolve. So the science is changing. We need to think of innovative ideas. And so what are some opportunities we can look forward to? Paulo, I'll go to you.
There are really a lot of great opportunities, especially in Congress, that we can look to. I think even if it is an election year, there are ways that we can continue to embolden the healthcare system. We know that there are strategies right now to look at how do we extend kind of chronic care treatment? How do we look at innovative payment models for taking care of patients through telehealth? How do we look at ways to pay for care for our aging population? And so there's some very good legislative proposals out there. Knowing that there is also kind of a challenge in Congress with getting anything passed, we are so pleased that this administration has made health equity a priority in all government programs. The Centers for Medicare and Medicaid Services, which are the largest payers of healthcare in the country, have really committed to pushing health equity in a lot of their payment models and a lot of their payment rules, which come out annually. We also know that the Department of Health and Human Services, working collaboratively across different agencies, are looking at innovative ways to tackle the social determinants of health. Their partnerships with the U.S. Department of Agriculture, the Housing and Urban Development Department to look at address homelessness. Really also HHS's responsibility to consult with the Department of the Interior for working with populations based in the territories and freely associated states, which make up a large part of the ANNHPI experience, is also a great thing. I'm also looking forward to really how can we start looking at an all-of-government approach, a health in all policies practice to think about healthcare beyond the silo of healthcare delivery. The pandemic has taught us that there are so many different ways that people experience healthcare. And how can we look at those upstream factors, and as we mentioned in public health, to really change individual health needs. And so the country is in a place that we can actually now talk about this all from the same quote unquote songbook. And we're hopeful that the policy proposals in place, the research in place, and also the interventions that we are all pushing forward, whether you're a provider, pharmaceutical industry, healthcare devices, or payer. How do we make it so that there is value in making sure that anyone who walks in through the doors of a provider or anyone who lives and works in a community is having the optimal health that they can have? And so we're looking forward to a multi-sectoral approach. We're looking forward, again, to looking at public health as being a major component to the healthcare delivery system in ways that we never really had, thankfully. One of the good things that came out of the COVID-19 public health pandemic.
Thanks, Paulo. Adam, how about you?
Yeah, I think there is tremendous opportunity in the healthcare system for addressing the needs for Asian Americans, Native Hawaiian, and Pacific Islander communities. And I think where I hope we are going is really somewhat similar to where APCHO members, the Community Health Center program, is grounded, is providing quality and accessible care to every single person, regardless of their ability to pay. And I hope that Congress will continue to keep that lens as they are addressing, and they're introducing federal legislation to address health equity in this country. And I think that there are several bills that are out there or that will soon to be introduced to help us get towards that. One area where I see a great opportunity is addressing the workforce challenges that many providers are experiencing. I know that there's a lot of interest in Congress to ensuring that there is support for hiring diverse workforce across the healthcare system, both clinicians and providers and support staff. And we hope that we'll be able to address some of those issues in this Congress before the end of the year. Soon, we are hoping that the Health Equity and Accountability Act, or HEA, will be introduced in Congress. This is comprehensive legislation that is a priority of the Congressional Tri-Caucus. So the Congressional Asian Pacific American Caucus, the Congressional Black Caucus, and the Congressional Hispanic Caucus to address every aspect of health equity for communities of color. This year, it's being led by CAPAC, as well as Congresswoman Barbara Lee and Senator Mazie Hirono. And we do expect that legislation to be introduced in the next several weeks. And this is legislation that in its entirety is not intended to be passed on its own, but that there are certain components that we're hoping can be pulled out and attached to other pieces of moving legislation to address whatever aspect of the healthcare system, because this gets everywhere from data to cultural and linguistic care to high impact minority diseases to the workforce challenges to social determinants of health and several other areas. So we do hope that that Congress will use that as a blueprint to addressing the unique challenges, not just of our communities, but all communities, all diverse communities in the country. And other pieces of legislation, like again, as I said at the very top, a significant portion of our communities are immigrant communities, and there are federal barriers that prohibit immigrant communities from accessing healthcare and other federal benefits programs while they reside in the U.S., particularly within the first 5 years that they live in the U.S. So we're hoping that Congress will eliminate those barriers. This is what's known as the 5-year bar, or the 5-year waiting period. We do think that Congress needs to remove that so that anyone who needs healthcare can gain access to the federal benefits programs that they may need. And if COVID has taught us anything, is that communities are only as healthy as the ability of the most underserved to get access to care. So we do hope that Congress will really pay attention to the lessons learned through COVID, invest in a workforce, invest in these cultural and linguistic programs, and invest in the ability for everybody to get the healthcare that they need, regardless of their ability to pay. And I do think that we do have opportunities within this Congress and definitely within successive Congresses and with the help of the administration. As Paulo was saying, the Biden administration has been great partners in these initiatives, and we hope that that they will continue and that any administration will continue to support our communities' health and well-being.
Thanks, Adam. Jennifer, I'll turn to you.
Thanks, Princess. A lot of great conversation has already taken place. Listen, it's clear that there is a great deal of work that we still need to do, right? So we need to continue to boost advocacy for the policy solutions that encourage health equity and access to healthcare. And to that end, we really look forward to further having discussions with Congress and the administration on the adverse impacts that the Inflation Reduction Act will have on patients, our research and development, and future innovation. So thank you for inviting me here today, and I look forward to partnering with everyone on the panel in the near future. Thank you.
Thanks, Jennifer. Dr. Ybarra?
Yeah, thanks. Thanks for having me. Thanks for having this really important conversation. It's been amazing to be with incredible colleagues that are doing really great work in the biopharma industry and in our partners in healthcare delivery. As sort of I started, I really feel like we're in this incredible time in medicine, and we have the potential for it only to get better. There are so many diseases that I see and take care of patients that are impacted by. where it doesn't have to be a death sentence. It doesn't have to be what I learned when I was in medical school. But at the same time, we're sort of developing these incredible new therapies, and the policy environment is really, really challenging for our industry to keep innovating. So that is what we do at the core. We all lived through the COVID-19 pandemic and saw firsthand the value that the industry provides. But at the same time, we know that we have too many patients and still need that hope. So in my view, now is not the time to undermine the ecosystem that brought so much value to patients and to society. And I hope that we can continue to work together to deliver that for patients.
Great, thank you. Adam, Paulo, Jennifer, and Dr. Ybarra, thank you for joining us today and sharing your insights on the impact of federal legislation on healthcare outcomes for the AA and NHPI communities.
Thank you.
Thank you.
Thank you.